I'd like to start by acknowledging the traditional custodians of the many and various lands on which we live and work and are joining this webinar this afternoon, and pay our deepest respects to their elders, ancestors, and future generations. I recognise all Aboriginal and Torres Strait Islander elders who may be joining us today, and also welcome Aboriginal and Torres Strait Islander people who are joining the webinar. We have a great lineup this afternoon. Let me start briefly by introducing and positioning the Northern Australia Health Service Delivery Situation Analysis and the team. This work was commissioned by the CRC Northern Australia and was the last of a series of situation analyses across Northern Australia. It was conducted by a team of researchers from James Cook University, together with our colleagues from the College from Queensland Health, CHHS, the Top End Health Service Northern Territory, and the University of Western Australia Rural Clinical School based in the Kimberley and Pilbara regions, Northern Western Australia. The members of the team were Ms. Alex Edelman, Associate Professor Steph Top, Dr. Nashila Moodley, Dr. John Grundy, Professor David Atkinson, Associate Professor Eddie Strivens, Associate Professor Bhavini Patel, and myself. Most of these members have joined us this afternoon as well. On our panel, we have Professor Sarah Larkins, who is a general practitioner and the Professor of Health Systems Strengthening and Director of Research Development at the Division of Tropical Health and Medicine at James Cook University. And we also have Mr. Jed Matz, who is the CEO of the CRC Northern Australia, based at the headquarters here in Townsville. A little bit of housekeeping. We will be opening the conversations to questions from the audience. If you look at the bottom of your screen, you will see a Q&A icon about in the middle of that bottom strip. Please use this tool to ask any questions, and I'll be keeping an eye on those. If you are noticing any technical difficulties, then please use the chat button for those. I will not be monitoring those for questions, but our technical team will be there to troubleshoot technical issues. We haven't received any questions before on the webinar registration page, so we'll just be doing these live or at the end of the presentations. But if something comes up that's relevant to what's being discussed at the point of the presentation, then I will be, with the agreement of the two presenters, I'll be interjecting those questions as they present. So let us start now, and please welcome Professor Sarah Larkins. Thank you, Sarah.
Thank you very much, Maxine. And I'm just going to share my screen. So I'll just get this happening. Good. Now, while we're doing that, I'm just going to add my acknowledgement of country to that of Maxine, and acknowledge that I'm coming to you from the Bindal and Walwarikaba countries here in Townsville. Maxine, are you seeing this correct?
Yes, and I'm seeing also that sidebar. No, the other one. Thank you, that's perfect.
Perfect. Okay, so as Maxine mentioned, this is one of a series of situational analyses commissioned by the CRC Northern Australia that took place. And this is the one for health sector the health sector delivery and workforce. And all this work took place over the period from August 2019 to February 2020. So a huge amount of work over a fairly short time. Maxine's mentioned the partnership that conducted the work. I'd particularly like to acknowledge the work of Alex Edelman, who was responsible for leading a lot of the direct work that took place here. We were also guided in this work by 3 expert advisory groups, one for each of the jurisdictions. And this was a total of 70 people who were involved in helping us guide and shape the project as we went through, and making sure that it really represented the views of people across Northern Australia. So what did we do? We did a scoping literature review of the peer-reviewed and grey literature. We found 910 records that were recovered, 573 were screened, reviewed 391 full text articles, and 324 of those were included in the final narrative synthesis. We also did an export and demand analysis, a research inventory of research activity and investment, a strengths, weakness, opportunities and threat analysis of health sector delivery in Northern Australia, and a costing study. For the costing study, we focused on preventable hospital admissions, which cost Northern Australia $241 million over the 2016 to 17 financial year. As an organising framework for these activities, we use the World Health Organization health system building blocks. There are 6 of these: leadership and governance, health information systems, financing, health service delivery, human resources, medicines and technologies. And as in common with many other projects, we added a 7th of people or community. So we produced a report from synthesising all these analyses that we did, and then took them right across Northern Australia to gather input from people right across the north. We conducted 17 consultation workshops to see how the degree to which what we'd put together matched up with the experiences of health service providers from all sectors across Northern Australia. So 16 of those were in person right across Northern Australia, were in the locations of the red dots, and one of them was by video conference. And in all, we had 110 participants in those consultation workshops. Excuse me, just lost my arrow. So when we look at the SWOT analysis, we had really a striking degree of uniformity of the key issues right across the north, and feel quite confident in presenting these to you. We looked at the SWOT from a variety of perspectives, and really according to a variety of different settings where care occurs. So we used a modified Monash model level of remoteness, and we added consideration of the different contexts of discrete Aboriginal and Torres Strait Islander communities settings, and also fly in, fly out mining sites as having different issues, and considered them separately. So what are the strengths and weaknesses, opportunities and threats? The strengths are, healthcare is obviously a very big industry. 13% of employment across Northern Australia is in health and social assistance. It's one of the largest employing industry. We're pretty good through necessity at training a fit-for-purpose health workforce, trained to do the right things in the right places in our context right across the north. And we're getting better at using telehealth and other e-health technologies to facilitate access to care for people who live in remote areas. Okay. So what are the weaknesses? We have ongoing problems in terms of health workforce shortages, and particularly in terms of turnover of the health workforce. We know that halving workforce turnover in the Northern Territory alone could save the government $32 million annually, so it's a big issue. We also generate inefficiencies through siloed systems of governance, finance and planning. We don't do joined up planning in a very efficient way. We're not linking up care right across the patient journey, so this allows people to fall through the gaps and become lost to care. And we're not working well enough with local communities in co-design to meet local needs. Another further weakness is under-resourcing, particularly of prevention and health promotion services and supportive infrastructure in some areas that we'll talk about a bit later on. What are the opportunities? We've got some real opportunities to strengthen recruitment and retention of the health workforce in areas of workforce need. We've got opportunities to review financing mechanisms and ensure that we, rather than just rewarding occasions of service, we reward quality care and outcomes. We can redesign things to support locally led needs-based planning, And there's a lot of opportunity to strengthen responsiveness, culturally responsive and community engaged service delivery and workforce. In terms of threats, the major threat for the health system is rising costs as a result of financing models that reward occasions of service rather than prevention of poor health. The financial spend in the Northern Territory is almost 11,000 per person per year compared to 7,500 nationally. The primary contributors to those costs are preventable hospitalisation and locum costs. The cost of the Aboriginal health gap alone in the Northern Territory is $16.7 billion over 5 years. So we've got a lot of lost productivity due to poor health and some more existential vulnerabilities, I guess, to emerging infectious diseases and natural disasters as a result of climate change in the north. So we've pulled out a few of our key findings that are the most relevant in terms of thinking about cross-sectoral investment and development moving forward. I've mentioned the high percentage of total employment in the north that's healthcare related. So there's really good evidence that supporting this workforce and investing in this workforce is critical to economic development in the north moving forward. This involves professional development for the workforce, working on cultural security of the workforce and practical things like working on housing and IT support for the health workforce and partner and family support. We need some integrated cross-sectoral investment in the social, cultural and environmental determinants of health. It's really critical. This is important both for the health of the population and also for the stability of the workforce. This includes housing, health hardware, ICT, access to land and house ownership, self-determination, roads and transport networks. We looked at the research investment and how that plays out across the north. We added up all the major government investment in research through the NHMRC, the ARC and the MRFF, and found that only $72 million, or actually 1.8% of health research funding from these bodies went to Northern Australian institutions. Now on a pure per capita basis, this should be about 5.1%. So we're clearly underrepresented in health research funding, which can be a very good investment. Furthermore, when looking at the type of research that's funded, the majority of it is clinical, biomedical and population health research, and only 11% of it is health services research, when our stakeholders told us clearly that there's a real need for policy-focused evaluative health services research, designing, implementing and evaluating place-based planning and new workforce models.
I could just interrupt there, Sarah, because you've used the term, and I see it's at the bottom of this slide too, that preventable hospitalisations. My understanding is that an admission to hospital for a condition where the hospitalisation could potentially have been prevented through the provision of appropriate individualised preventive health interventions and early disease management, usually delivered at primary care and community-based care settings. Yep. So a better investment in health services research would also help try to reduce that preventable hospitalisation to do fit for purpose in the region. Would that be a correct assumption?
Absolutely, Maxine, and in fact, another name for potentially preventable hospitalisations is ambulatory care sensitive hospitalisations. So those hospitalisations that are preventable by attention to strong primary health care.
Thank you.
So that's absolutely absolutely a correct assumption. And in fact, the next point there is about the potential for, what's happening here? Was about the potential for strengthening, for the need for strengthening strong comprehensive primary health care. and place-based planning and needs-based financing to generate more efficient, equitable and effective health services. And part of that will be through primary health care. So as Maxine alluded, we found here that 6.6% of all national preventable hospitalisation expenditure happens in Northern Australia. So again, we're overrepresented on a population basis in those admissions, which really, as Maxine said, are a function of inadequate primary health care or inadequate access to primary health care. So what does this mean for the priorities for future health and health sector development in Northern Australia? And you know, likewise, perhaps some CRC investments in the health stream. As a result of our work and our consultations, we came up with 8 priority actions. And one of the things that was very obvious in our stakeholder consultations was and also in the literature and the other work we studied was that health workforce training and support are sort of numbers 1, 2 and 3 from many people's points of view. So we've put the first 2 recommendations around health workforce training and support. The third recommendation is around establishing a cross-jurisdictional body to do some joined up planning and regulation. The fourth one is around a financing review to produce some more equitable funding models. The fifth is around the health enabling infrastructure and putting in place some attention to the cultural and environmental determinants of health. The sixth recommendation is around getting better at implementing place-based planning. The seventh is around Northern-led research and bringing in more research into Northern Australia, building capacity for that. And the eighth is around health as an export industry. So I'm going to go into a little bit more detail about each of those. On the 4th page of the 4-page summary report, this is a process map, really looking at the relationships between the 8 priority actions that I've just mentioned with the guiding principles that help those, the steps required from our perspective and the broader implementation, and the way that these together could lead to a strong, more effective, equitable and efficient health system in the North, delivering better outcomes. So let's go through these individually in terms of the recommendations. The first recommendation was around supporting and enhancing formal education and training of a fit-for-purpose health workforce. So this needs to be across all disciplines and it needs to cover all elements of the rural health training pipeline. It's really important that we train students from, in, with and for underserved communities in the region. So that goes from selection of students into all disciplines, training them in appropriate places, providing appropriate postgraduate training, and really importantly, holding ourselves responsible for monitoring the outcomes in terms of where they go, what they do, and whether they're meeting the priority health needs of populations we serve. The second recommendation is really around support for that health workforce to address that issue of turnover and try and retain more of the health workforce. That can be done through enhancing professional support, supporting career development and career pathways. And a large part of that right across the region was about the need to support the Aboriginal and or Torres Strait Islander health workforce, whether it be increasing the number of Aboriginal and Torres Strait Islander health workers, increasing Aboriginal and Torres Strait Islander peoples in non-clinical roles or as doctors, nurses, allied health practitioners at all levels of the health workforce. We know that supporting retention can save considerable funds for Northern Australian health services and also contribute to quality care and continuity of care and increase trust of community members in the health service. Attention to retention can actually save up to $50 per consultation, according to some modelling done in the Northern Territory. And we need to provide support, including postgraduate generalist training options in the regions. so that people aren't forced to go away from Northern Australia to do their postgraduate training. The third recommendation was around establishing a cross-jurisdictional Northern Australian health system network as some kind of an independent body with the functions of sharing knowledge and experience about what works well, working towards the holy grail of data interoperability, which is would really facilitate following quality healthcare for people who are quite mobile across the north. Joined up credentialing processes for health professionals, enhancing cross-border service provision, recognising that people don't just stay on one side of the border or another, they move backwards and forwards, and perhaps considering shared clinical practice guidelines right across the north. So through these processes, we can deliver some more harmonised processes and strengthened local planning right across the north. We'd like to see a review of financing mechanisms and consideration of mechanisms that might finance appropriate health service delivery models. And this involves really considering the notion of funding a minimum equitable viable service. We need the funding to be based on need and reward quality of care and outcomes, not the current system that rewards occasions of service, often with perverse incentives for service delivery and throughput. With the funding distributed as close as possible to the site of service provision. Sorry, Maxine?
Yeah, so just on that, a couple of places have changed from episodes of care to a more equitable type of financing. Did we get any feedback about whether that has improved things in those locations?
Yeah, so where services are able to buy, to control their own funding and buy-in services, there is some preliminary evidence of better health outcomes, but it's still pretty much in the early stages in terms of doing that. The community control health setting is actually quite a good example of being able to do that, you know, where the funding is distributed in a block grant model and to some degree the services are able to design and deliver their own services according to the needs of the community, yeah, it's still a bit more work to do in terms of outcomes, but a good start.
And I've just got another question here too. It's actually back on your previous slide about workforce development. And just also think about the need to build capability, or was there discussions about the need to build capability in e-health and telehealth as part of business as usual?
Yep.
Were there any initiatives included?
Yeah. So yeah, very mixed views on e-health and telehealth throughout the consultations. So certainly it was recognised to be part of the solution generally, and considered to be a positive and a negative, and very much to be used as a supplement to existing on the ground services rather than a replacement of existing on the ground services. So in terms of building the capability and capacity of the health workforce, yes, training to use whatever model of service delivery was put in place to meet the needs of the community was an important part of that.
And I suppose we should note that this was done before we got a pandemic come along that is actually fast-tracked, but also maybe exacerbated a few of those things, and it would be worthwhile probably looking at how that has affected both the services for these needs, but also the changes in funding models that have occurred in response to the pandemic. Yeah,
absolutely, and we know there's a lot of work going on in terms of evaluating the response to the rapid uptake of telehealth initiatives, and there's been some really positive outcomes from the COVID pandemic and the rapid uptake, and there's also been some slightly negative outcomes that need to be corrected for and adjusted for in governance on the run, I think.
Thank you.
Thanks. Great. So I'll move on to priorities, the priority actions 5 and 6. So priority action 5 was, again, wherever we went, it was highlighted that the social and cultural determinants of health were not by any means dealt with in Northern Australia, and that a lot of action was needed on this before any real difference in health outcomes would be seen. So a very unanimous view that there was a need for intersectoral action to improve local amenities and infrastructure. So the action here was around housing, around transport, around information and communications technology, around water and sanitation, but also importantly around land ownership and self-determination and those broader social and cultural determinants of health. And food security, importantly, having access to fresh food. The 6th one was around developing and scaling up place-based planning models and strengthening local comprehensive primary health care. So there have been some good demonstration projects of this happening, but really some broader implementation and trials are needed to enhance our knowledge of how best to implement these processes. This is where people also talked about telehealth as a supplement rather than a replacement for existing services. And there's a real potential to improve health equity and efficiency through local co-design of services to meet local needs and real financial savings, as mentioning earlier, that can result from that. So, for example, again, some figures from the Northern Territory from work led by Menzies found that investing $1 in primary healthcare in remote communities could realise savings somewhere between $4 and $12 in public health expenses, and that's above and beyond the health and social benefits for the individuals concerned. So a really strong economic argument for that. And the last 2 priority actions around Northern-led research capacity building and funding. So we need to build and grow capacity to explore, design, implement and evaluate solutions to the Northern health sector service delivery issues. There's a really good economic argument for this as well. There's a KPMG study from 2018 that showed a return on investment of $3.90 for every $1 invested in health research. But it's also important because it is likely to deliver feasible, sustainable and contextually informed solutions to the regional health service challenges that we face. We thought, and this was supported by the stakeholders, that this was best delivered through strengthening capacity and through local hubs of service reaching and training activities. And this is often referred to as activated learning health systems. So hubs of health service delivery that are also involved in education, training the health workforce, conducting research. The 8th recommendation was the most contentious or contested amongst the stakeholders, I think it's fair to say. We were asked to explore potential areas of export opportunity that deliver value for Northern Australia. It was felt that there was a place to do this, but it was particularly likely to be exploring opportunities around education and training of a fit-for-purpose workforce. So that's both in clinical skills, but also public health skills, biosecurity, education and training around all of these areas. And that through doing this, we could perhaps deliver value and effective two-way learning and partnerships for Northern Australia. Would need to be done through a partnership with an organisation such as Austrade, and really with that idea of strengthening regional health sectors and relationships rather than for a pure economic argument. There were consistent notes of caution sounded about this by our stakeholders due to ongoing gaps in our existing health capabilities across the north. So some caution around that, but something that we can cautiously explore moving forward. So that's all I have to say. Very happy to answer questions. And this was by necessity very much a sort of flitting tour of what we've talked about. I do commend to you the full report and the summary report that are both available on the CRC Northern Australia webpage under resources and publications. These hyperlinks also work for getting the publications. So thank you, Maxine. I'll hand back to you and we'll move forward.
Thank you, Sarah. And yes, a large body of work across a very vast region of Australia. There was just one comment, and maybe Jed, you can also pick this when I invite you to talk. If you just go to your third slide, sorry, Sarah, somebody was asking, why wasn't Rockhampton included? And I suppose there's a couple of answers to that, but in the consultation, I suppose you did, just because we didn't visit doesn't mean that people's views weren't sought from a broad range of areas. But also, Jed, maybe when you present, you can just explain how the CRC Northern Australia defines Northern Australia as well, so that others might understand what's in and what's not in. But Sarah, have you got any other comment about, you know, how we engaged a broad range of views from that jurisdiction?
Yeah, we followed the CRC Northern Australia definition of what's in and what's out, and did use video conferencing to get views from people in as many areas as we could. We had 2 or 3 months to do the face-to-face consultations, so we didn't get to Rockhampton. But you know, as you can see, we got face-to-face to 16 places right across Northern Australia.
Thank you. There's no other questions at the moment, so I'll keep the line open for people to be able to add them in. But now, thanks a lot, Sarah. It was fantastic. It was good to see it all again and hear the presentation. So I'd now like to invite Mr. Jed Matz, who's going to provide some brief responses to the situation analysis and recommendations from the CRC Northern Australia perspective and outline some next steps. So thanks, Jed. We're looking forward to hearing this.
Thanks, Maxine, and welcome everyone. Thank you for your time today. I'll try and keep this as quick as possible so we can get into questions and get people home at a reasonable time. I'm assuming the screen's come up and is working. This is the area of operation, which is perfectly timed slide, given the questions we've had. So we do dip down and cover Rockhampton yeah, ideally, you know, we would like to get around with all of our research and consult as widely as possible. In this instance, within the constraints of time and budget, Rockhampton wasn't reached. However, for that person who asked that question, if they don't feel that any issues were raised or covered that are unique to Rockhampton or that region, then we'd be happy to take the feedback and look at what we can do further to express any unique issues that might be specific to Rockhampton that currently we're not addressing. We've got a head office in Townsville, which is where I am, a staff member in Cairns. We operate a single person office in Darwin and a single person office in Broome, ensuring that even during these travel restricted times, we can get boots on the ground around Northern Australia and make sure that we're talking to the right people and we live and experience everything that those people do in Northern Australia. Our board is 7 people, also spread across Northern Australia. Our chair from Cairns, Sheridan Morris, our deputy chair, Don McDonald, and directors, John Wharton, Mayor of Richmond, Peter Long, Mayor of Karratha, John Bean from Townsville, and Ricky Archer from the Northern Territory. There was a seventh one, I should say, Tracy Hayes from the Northern Territory. She's recently stepped down while she contested the NT election, and then that'll be resolved at our next AGM, a replacement for her, whether she restands if she's not elected to the NT government. So in terms of how we prioritise our investment for Northern Australia and how this work fits into that process, the CRC is established under the White Paper for Developing Northern Australia, and our job is to de-risk Northern Australian development in the areas of agriculture, health service delivery, and traditional owner-led agriculture or health service delivery development. So there are three levels or elements to that type of work. You see the blue triangle there is about the work that's necessary to de-risk the investment environment from a policy and regulatory position. So that doesn't necessarily mean reducing regulation. It just means trying to work in areas and provide information and research that improves, streamlines, or makes more efficient or more transparent the regulatory process so that people find it easier to invest or develop. And that is a lot of some of the work identified in this health sector analysis is definitely going to feed up into that area where we're looking at how can we do health service delivery better, what are the policy tweaks we need to make, what are the budgetary changes that are needed, and what further data can we provide to help underpin those decisions. Within the brown line is our sector and regional supply chain analyses, and that's where this work was funded from, and there'll be ongoing need to further research sectors and supply chains and understand what further research they need to help those supply chains develop and grow. And then our final level of investment is, I guess, what we call our industry-led research and development, which is more applied research on farm gate, and in medical practice type research that delivers impact on the ground directly. This research project that we're talking about today fit within the fifth research, I guess, priority of health service delivery within our research programs. But obviously, because it's a situational analysis, also cuts across sector and supply chain development and de-risking policy solutions as well. So we've made two investments in health service delivery in addition to the situational analysis. We've invested in a project to develop a more robust telehealth system, which is being led from Northern Territory, and we've also invested in the SARA project, helping to establish improved eye screening services in Indigenous communities. There have been a few other projects we've looked to invest in, but for various reasons, we haven't been able to get them off the line at this stage. But obviously, we are looking for more projects in the health service delivery area, which brings us to our announcement today that we're opening our next funding call, looking for projects. So that funding call will be open until the 30th of September. So I'd encourage you to go on our website and find out what we're looking for. These are the priorities. So we're looking for projects that are basically under the health analysis area or traditional owner-led analysis. So, beg pardon, I might have missed a slide there. Yep, here we are. These are our research priorities for the funding call. So the first one is about mapping the community needs against the existing service delivery and workforce within Northern Australia. We felt like this mapping would really help underpin and support recommendations 1 through 6 from the situational analysis, underpinning further knowledge about what education and training is needed, underpinning more about what professional support is required within the cross-jurisdictional group, providing data for interoperability as well as local planning information, helping provide information about what financing models could work under recommendation 5, understanding that local infrastructure need better, and then place-based planning for number 6. That data is in our situational analysis at a high level. This next level of mapping that community need against what's already there will really give us that local feel to start to really do some integral planning. The second recommendation or priority that we're looking to explore is around that 8th recommendation around the opportunities to develop export industries out of the health sector. As mentioned, very contentious. Splits the room, that sort of one. Should we be doing looking at developing export when we could improve what we do back home? I think there's room for both, but we are looking to see what opportunities are there and how to develop that sector. And we think developing that sector could be a pathway to underpinning our own delivery back home. And then more open questions for the last 2 dot points around what new models of healthcare are available and identifying gaps in integrated care. So just keeping it quite open there so that people can bring to us ideas and new research that we might not have thought of yet. So these are the key dates for the funding call. Monday, obviously today, we opened up, and if you've got any questions, we'll accept questions up to the 23rd of September. We put them on our website so that it's fair and open and transparent. Everyone gets the same information. Then EOIs will close on the 30th of September. We go through an evaluation process that encompasses advisory groups that we've set up from 3 jurisdictions. And by January next year, we should hopefully have indicated if that expression of interest is supported by the board. So please call us if you've got any questions about that process. There's some links on our website for various information that will help you, and welcome any questions about that today as well. I might just leave it there, Maxine. There's some further information you can use to get from us, and back to you.
Thank you, Jed, and that's very exciting and a welcome announcement today. Maybe it can help fill some of that funding gap that we saw in research, applied research and health services research for Northern Australia. So that's fantastic news. Jed, I haven't got any questions at the moment up there, but I just wanted to ask you also, what's the relationship between the work that the CRC Northern Australia is doing in the health sector and health systems research and guidance to our political colleagues? I know that the Northern Australia conference is coming up soon, and I think there was some other fora that exist. So how do they link? Because that was something as we went around Northern Australia, people were trying to understand that link between the work of the CRC Australia research in health services and the development investment by our governments.
Sure, thanks, Maxine. As I mentioned, because we were established as an initiative within the White Paper for Developing Northern Australia, our bid as a CRC came together in a completely unique way in the sense that we don't have partners yet, and as we do projects, we bring them in as part of the partnership. Most CRCs have all that worked out at the front end and worked through. So it gives us a bit of political impetus to be driving development and de-risking work, because that's what we're set up to do, and to feed into the government information, and all 3 jurisdictions are partners of the CRC along with the Commonwealth. So all the governments are talking to each other as part of the CRC. And that actually then feeds, or up until recently, fed into the Northern Australian Senior Officers Group, which then fed up to the Northern Ministerial Forum and into COAG. And so you get through undertaking research, providing new ideas, policy ideas, data, you could then feed into either take those reports directly or often we distill those reports into a larger narrative, one of which is our State of the North report, which we've identified workplace and training as major issues for agriculture as well as health. So that's a synergy that we would go to government and say, it's not just health that needs improved workplace, and we take that to government. Unfortunately, now that they're rejigging the COAG arrangements, I'm not sure exactly what that looks like yet because we're still learning, but we're very confident that something will replace that Northern Australian ministerial structure, and the CRC can feed directly up into that influencing government through their normal cycles. But right now we're focusing on the refresh of the white paper for Northern Australia, which is currently being done by our task force. It's also populated by all the jurisdictions in government.
Thanks, Jed. And I suppose also thinking about the other synergies. I mean, Sarah mentioned also the investment in telecommunications and internet communications technology. And I know that that's been identified in some of those situation analyses. So there are, I suppose, Northern Australia development opportunities that are win-wins for many of the sectors. And I suppose that's part of the role of you as a CRC, Northern Australia, to try to look at those synergies as well. I have got, and maybe I'll put this to you, Sarah, but also to Jed, a question: how can clinical units with limited research capacity get involved in the EOI by partnering with academic groups? Is there a process that either the CRC's put up, or I suppose Sarah, from an academic group point of view, and even some of the others from Western Australia and Northern Territory who are on our team, how might that be possible?
I can go first, Maxine, if you like. Thanks for the question, Andrew. Great question. There are lots of initiatives to facilitate that, and I think sort of practical action research to solve priority problems is always stronger when it consists of a mixture of sort of clinical expertise and sort of people on the ground delivering services and the academic expertise. So there are a few in all the jurisdictions. There are sort of gatherings that facilitate that type of an action. So for example, there's the recognised Centres for Innovation in Regional Health in Central Australia and in North Queensland that facilitate partnerships between clinicians of all stripes in right across the regions. There's a similar grouping, academic and clinical grouping in Northern Territory, and similar groupings actually around the Kimberley region where there's very active academic units partnering up with clinicians. I'm sorry, I'm not quite sure where you're based, but there will be a UDRH or an academic body close to where you are that will be interested in your input. So,
and can I also just add to that, Sarah, I suppose, and you might want to answer that, and then I've got another question for you that's just popped up. That could be similar for maybe community-based groups, so faith-based organisations, community-based organisations, community-owned service groups that would also want to be involved. That type of arrangement's possible for them as well. Yeah. Jed, did you want to answer that as well, or will I pass you the next?
I think Sarah's response was very accurate in the sense that we look more favourably at research proposals that have really wide partnerships and bring together various parts of the health sector. CRCs traditionally are industry-led. Health is one of those odd ones that not obviously the industry is the patients, but the health service delivery people are really the industry in this sense, and then partner with researchers. If you're struggling to find or identify the right partners, give the CRC a call. Part of what we do is broker ideas. So if you've got a great idea but you haven't got the right partners, we can use our networks or the people that we know to reach out and try and find the right partners for you as well.
Thanks, Kevin. I mean, that was part of the question that's been popped up. I've got two other questions. We're probably getting close to time. Who is an industry partner for health, given the small number of private actors operating in the space? And as you said, you're taking the health industry, anyone who provides health or workforce training or those aspects are the industry. Is that correct? Yeah. And then part of that is, do you have a budget spend for health projects, given that it has received extremely small amounts of CRC Northern Australia investment to date?
Yeah, well, there's to give people a very clear idea of how much we have to spend. We have a 10-year life cycle, $75 million of Commonwealth funds to invest over that time, and my job is to match that 1-to-1 with cash and in kind. So I would flag that we look at projects that have cash components much more favourably in their proposals. And of that, we are focused on agriculture, health, and traditional owner-led. So when you break that down, roughly you're looking at $7.5 million a year, to run the CRC and invest in research. So it is when you start to spread that across all of Northern Australia, it's really starting to get thin. So we're very careful with what we're doing investing. And whilst I don't like to put numbers on things, we haven't sort of said, right, this much is going to health, this much is going to ag. We've got ag is our highest priority, and then health is our next highest priority in terms of funding. And it's really about what projects to get and what the return on that investment would be. So we've done small projects, under 100,000 from us, and we've done other projects up to $1 million from us. So it really depends on how good the project looks. And one of those projects was a health one that we allocated $1 million to. We just couldn't reach agreement with the partners around certain things, and unfortunately couldn't around that. So we're not going to shy away from investing in health, but it's got to be the right project.
Okay. So Sarah, questions really for you around, and maybe we've only got a few minutes left, so maybe just a couple of the key education and training needs in terms of workforce development that were identified through the situation analysis, and then I'll finish off with the last question for Jed.
Yeah. So there are lots, and we deliberately didn't focus on any of the specifics in this, or else we would have been here all afternoon. Probably one of the biggest ones was getting training for Aboriginal and Torres Strait Islander health workers or health practitioners right across the sector, and there've been a multitude of issues that have developed in that space, and so it was recognised that it was really important to get that happening in a way that enabled people to train largely in their communities and without having to go away for long periods for training, but training all parts of the health workforce in a way that was appropriate to the context. So selecting from the areas, providing training on the sort of priority health needs, and ensuring that the whole pipeline was supported across the workforce was also important. But yeah, I'd say the Aboriginal and Torres Strait Islander workforce was the biggest.
Thank you, Sarah. And again, a good reason for you to go and read the report and see some more of that detail and the evidence for that. And then, Jed, the last question I've got up is again, many of the identified cross-sectoral and cross-jurisdictional challenges in the report are not being addressed even now by the current funders, which is why we still have these problems. CRCNA is already a cross-jurisdictional and cross-sectoral body. So how do you see the role of the CRC in driving change and making linkages that some of these other funders haven't been able to do? Just give us the solution now.
That's a great question. I mean, what a tough job we have, really, not only in health but in Northern Australian development. Everyone knows the opportunity, but there are so many challenges. One of the recommendations from your report is the cross-jurisdictional working group to start to bring together the decision makers and key players, and I think the CRC would be very supportive of that framework, and would look to not only support the framework but also feed research into that to give it some arm's length research that they can start to make decisions on how they can better share data, share services, move patients east-west as opposed to north-south, and think about those sort of things, which is almost unheard of, I think, in health, not coming from that background. But we see the same problems in agriculture as well, about just moving animals across borders, so let alone people, when it comes to biosecurity. So support that, and again, I'll come back to the way we feed into these co-ag type arrangements. We're able to feed those issues to politicians who can actually then support and drive, from the top as well as from the bottom, some of the stuff. So it's not going to be easy, but just through investment and support.
Thank you. Good. So obviously, I mean, we could go on. People are just totting up with their questions closer to the end, which is often what happens. As Jed said, and also at the end of Sarah's slide set, we've also put ways that you can contact us if you want to find out more detail around the situation analysis and its findings, but also, as Jed said, around the new call and expressions of interest, but also if you feel there are other things that were not as well represented as you had hoped would be in the situation analysis. But read the report first. It's very detailed. We couldn't show all of that in the 20 minutes we did today. So first I'd like to thank again today's panelists, Sarah and Jed, for their time and their expertise. We have recorded this webinar and it'll go up on the website in the next couple of days, along with copies of these presentations and those links of resources and other details around the calls that have just been announced today. So again, thank you very much everybody for joining. It was nice to see such an interest in Northern Australia, and now I hope we can see that translated into, as the last questioner said, into action and trying to get some more collaboration that makes real changes for the health sector and the population of Northern Australia. Thanks for joining, and we look forward to hearing from you in the future. Thank you.